Today we are going to talk about the definition of heart failure and what are the recent advancements occurred in that. This webinar, I along with Dr. T.Seshikant is a senior consultant working in Yashoda Hospital. Both of us are discussing this topic. Actually, we wanted to say what is the need of talking about this heart failure at the present scenario. If we see the definition of the advanced heart failure, it can be defined as stage of heart failure characterized by advanced structural heart disease and marked symptoms of heart failure at rest, despite dietary modification, salt restriction, and maximal medical therapy, including AC inhibitors, angiotensin II receptor blockers, digitalis, diuretics, and beta blockers. These patients require frequent hospitalizations, and the overall prognosis is poor in them. To define, actually heart failure is not a disease, it is a syndrome. There are as many as 200 causes are there which can produce the heart failure. Heart failure comes in all ages and can be hard to diagnose sometimes, especially associated with a respiratory problem. The prevalence of the heart failure is rising throughout the world. This is mainly because of the aging population, and the second one is growing incidence of obesity, diabetes, and hypertension. And the most important one is there is improved survival after the myocardial infarction and a success in preventing the sudden cardiac death, leading to increased incidence of the heart failure. Fortunately, therapies that have emerged during the past few decades can greatly improve the outcomes in heart failure patients. If you classify the stages of the heart failure, the stage A represents high risk population without any symptoms. The stage B, the patient has a structural heart disease but doesn't have any symptom. Stage 3 is the structural heart disease is present. Either previous or current symptoms are present. In stage B, the patient is in the refractory symptoms requiring a special intervention. The famously known as heart failure with a reduced ejection fraction is very important because it has a very bad prognosis. 15% die within 3 months of diagnosis. 40% die within 2 years of diagnosis, whereas 87% will die within 10 years of diagnosis. Of course, ischemic patients die sooner. The bad prognostic markers are the low sodium, very large heart, that is gross cardiomegaly, and arrhythmia. Of course, one of the biochemical parameters which is important associated with the increased risk of the death is the high norepinephrine levels. As I already mentioned, the diagnosis of the heart failure is very important. It is in the 3 stages. One is the patient comes with a breathlessness, and then we suspect the heart failure, but with a proper clinical history taking, like the previous history of the coronary artery disease, presence of the hypertension, exposure to the cardiotoxic drugs or radiation, previous use of the diuretic, history of orthopnea and paroxysmal nocturnal dyspnea, then our suspicion of the heart failure increases. Of course, combined with the physical examination which shows the rales in the lung examination and bilateral ankle edema, presence of the heart murmur, rise in the jugular venous pressure, and laterally and outward displaced heart representing the cardiomegaly almost confirms our diagnosis. In addition, if they have the ECG abnormalities, then we can further proceed for the diagnosis of the heart failure. So, out of the clinical history, physical examination, the ECG changes which are mentioned, more than one are present, then we have to test the natriuretic peptide. Either we can go over the NT-proBNP if its levels are more than or equivalent to 125 picograms per ml, or BNP levels greater than or equivalent to 35 picogram per ml. Then we have to go for echocardiography that confirms the decreased ejection fraction. Almost we are certain about the diagnosis of the heart failure. Then we have to further investigate for the cause and what is the appropriate treatment. If none of these signs, clinical history, physical examination, ECG changes are not there, then heart failure is unlikely. Then we have to consider other diagnoses. Even when the natriuretic peptides are elevated, then also if the echo is normal, then also we have to think that non-cardiac conditions like the chronic kidney disease, other muscular disorders, increasing the proBNP has to be suspected. Of course, these are the different cutoff points for the enzymatic levels to say that heart failure diagnosis is required. So nowadays another concept has come, that is mid-range heart failure. When it is more than 50% of the ejection fraction, it is considered as a preserved ejection fraction, heart failure associated with the preserved ejection fraction. And if it is less than 30%, then definitely we can label them as heart failure with a reduced ejection fraction. But the gray zone is between 40 and 50%. These people differ phenotypically, and potentially different treatment strategies are available, and underlying characters pathophysiology are different from than other two varieties. That's why this heart failure with mid-range ejection fraction is gaining importance in the past 2 to 5 years. In this, mainly depending upon the signs and symptoms, along with the mid-range ejection fraction, structural abnormalities and functional abnormalities also to be added to diagnose. Sorry. The structural abnormalities are mainly in the form of left atrial volume index more than 34 ml per square meter, and left ventricular mass index greater than 115 grams per square meter for male and 95 grams per square meter for females. Functional abnormalities are in the form of E by E prime ratio greater than 13, and E prime average is less than 9 centimeters. Then, of course, we have the limited data to talk about this mid-range EF, but it requires a special attention when we are managing the heart failure patients. The ESC guidelines for the heart failure, once we diagnose the heart failure, is mainly depends upon the diuretics in the acute symptomatic stage. That is a class 1 indication. After that, the therapy with ACE inhibitor and beta blockers are mandatory, and we had to up-titrate to the maximum tolerated dose. If still the symptoms are symptomatically patient is a dyspneic and LV injection fraction is less than 35%, then add an MRA. Still the patient is symptomatic, injection fraction is still less than 35. Then we have to see for the ACE inhibitors and ARBs, and see for the heart rate, and see for the QRS. If the QRS is more than 130, and then probably going for the CRT is helpful. And instead of the tolerance of the ACE inhibitors, ARBs are tested not effective, then we can change it to the RNA. And if the sinus rhythm, heart rate more than 70, probably addition of the ivabradine is going to be helpful. Even with all these measures, the resistant symptoms are there, then probably we have to consider the digoxin and hydralazine with long-acting isosarbidinitrate or left ventricular assist devices or heart transplantation has to be thought. If the resistant symptoms improves at this stage, then probably we can think of the decreasing of the diuretic. So what I want you to pay attention is that digoxin is considered as the last management strategy, which was actually considered as in the initial stages of the digoxin. This is to summarize, when the patient is in NIA class 2 to 4, the class 1 indication for the diuretic to start when a patient is in the congestive symptoms, and replacement of the ACE inhibitors along with RNA whenever is required, or addition of the MRA as a class 1 indication, or ARBs itself is a class 1 indication. All said and done, we should know about our Indian scenario because we are practicing in India. So actually to say no data on the profile of heart failure and practicing patterns in India are available. The major thing, as we already know, is random heart failure registry. This study actually supported by the ICMR. That's why the importance is given, and I will go through a little bit in depth about this history. This is, as we already know, that it is a predominantly disease of elderly, and as age increases, the incidence of the heart failure also increases. So the burden of the heart failure is likely to rise with the growing age of the population in India. Previously it was in 58 years, which is a decade back. Now our survival rate is increased to 72 years. The number of the people above 60 years of age in the region projected, that is from India, is increasing from 133 million in 2011 to 494 million in 2050. There is no reliable data regarding the incidence and the prevalence of the heart failure in India. As I already mentioned, Trivandrum's heart failure registry, and it is done in 1,200 patients from India, and out of them 31 are females. When compared the age distribution, till the age of the 56th or 6th decade, males are the predominantly suffering with the heart failure. In the 6th and the 7th decade, the females are dominating, and as well as in the 9th decade also. And of course, there are the very limited data beyond the 9th decade. And with an average age of this population is about 61 years, and with a preserved ejection fraction in 25% of the cases, predominantly it is because of the ischemic cardiomyopathy in 36% of the patients, and acute coronary syndrome in 35%. If you take the miscellaneous conditions, which are also important nowadays, increasing in incidence, that's why separately I am mentioning what is the incidence. Non-rheumatic and valve diseases constituting about 2.5%, right heart failures isolatedly are contributing to 1.5% according to this series. Congenital heart disease is 1.3. This is mainly because of the surgeries is not increased in the childhood to reach them to adult to have the heart failures. And peripartum cardiomyopathies are contributing about 0.25%. This is in comparison of the Western and the Japanese series. It shows that there is a slightly increase in the ischemic component of the Indian population. Of course, the rheumatic is dominating. And of course, the other series are not mentioned about the smoking, but smoking is a very, very high risk factor, almost equivalent to that of the hypertension and the diabetes in Indian scenario. Hospital stays are also longer once the patient comes with an acute heart failure in Indian scenario than when compared to the Japanese series. Sorry. So also hospital mortality, it is about 8.4%. And whereas in ADHERE trial it is as low as 4%. But in general, it is varying between 4 to 8%. So what are the actual differences between the Indian heart failure patients and the West? These are the 10 years younger and male predominance. Usually above the 70 years, the females are predominantly develop the heart failure. But in our scenario, it is males are predominant. And more commonly, CAD is the cause for the heart failure. In-hospital stay is longer, and in-hospital mortality is higher. 1 year mortality is about 31.7%. And of course, this is the same as that from US and Europe. This means to say there is a difference in the in-hospital mortality in the acute stage when compared to the chronic management. Usage of evidence-based therapy was not very different from the West, but it is suboptimal. So we had to improve our methodologies of treatment. Of course, there is another important study from the South Asia. This is mainly to say that the rare causes of the heart failure also. In this also, ischemic left ventricular heart failure is a predominant one. And another study which requires attention is AFAR study from the Sandeep and Shea, that is acute failure registry. In this, hospital mortality was 30.8%, and the post-discharge 6 months adverse event rate is as high as 39.5%. So this registry has demonstrated that is in hospital as well as the late mortalities are very high in the Indian population. We collected out the data from the Nizam Institute in the past 6 months. There are about 2,272 admissions in ICCU. Out of them, 140 were purely due to the acute heart failure, requiring admission to the ICCU. That counts about 6.2% of the ICU admissions. This is excluding the acute coronary syndromes. The average is about 57.14 plus or minus 14.1, which is almost like that of a Trivandrum series, that is then 61%. And here the males are the predominant. In-hospital mortality is 5%. It is slightly less. I don't claim that the Nizams is better than that, but it is probably that is an earlier study, and this is the latest results what we are saying. This must have been improved the management of the acute heart failure in all hospitals in every way throughout the India. Dr. Seshikant, what I think is till now, just I gave the gist about the heart failure and its outlines of the management. Can you tell us about what were the previous approaches for the heart failure, and what is the greater change occurred in the heart failure management recently?
Yes, Dr. Jyotsna. It's very important to understand that we have a very large population who are having advanced heart failure, difficult to treat heart failure, and we need more and more newer drugs, newer modalities, newer approaches for this management of this epidemic of heart failure, as Dr. Jyotsna has put in initially. We are mainly talking about management of stage C and stage D heart failure today, and we have a lot of approaches for refractory heart failure. One is to optimize the medical therapy, give the drugs at the optimal doses, what have been given in the trials in most of our patients. Titrate the drug as much as possible and see if you can give the drugs at the maximum tolerated doses. This is very, very important, which we are not really doing in our day-to-day practice. Patient treatments. Second, a very important modality of treatment is the cardiac resynchronization therapy and the role of the implantable cardioverter defibrillator in the management of heart failure patients. Most of the patients in class 2 and class 3 heart failure have sudden cardiac death as an event which happens. And this event is quite high in stage 3 heart failure and stage 4 heart failure. The maximum benefit over and above the medical therapy is achieved by giving this cardiac resynchronization therapy or ICD in very appropriate, where the very appropriate usage criteria are used. You can get about 38 to 40% reduction in mortality in these patients. So one is optimizing the medical therapy. Two is using the devices to reduce the mortality for these patients and give them a better quality of life and better quantity of life too. There are some drugs which have been, their role have been used in reverse remodeling of the heart enlargement. One of them is the drugs where you have the ACE inhibitors and the AR2 blockers. Second is using CRT, cardiac resynchronization therapy, using some surgical modalities to reduce the cardiac size, like repairing the LV aneurysm, or using some interventional mitral valve repair techniques wherein secondary cardiac dilatation is prevented, wherein you can do some annuloplasty, repair the mitral valve ring, reduce the cardiac size, reduce the size of the mitral regurgitation, and do some various other modalities are there, which we will be discussing in the subsequent slides. We are also into stem cell, wherein we are stimulating the endogenous stem cells. We are using the gene therapy. We are trying to do some left ventricular assist devices, wherein we are trying to replace the heart, the diseased heart, with some artificial hearts like HeartMate 2, HeartMate 3, and probably as a destination therapy or as a bridge to transplantation. And one of the most important things today we have in our armamentarium is cardiac transplantation, which is a reality today, which can be done at a good number of centers in India. And we can definitely initiate the talk, consider cardiac transplantation in appropriately suitable patients. So let's look at the newer modalities of therapy what we have. When we started the treatment of the heart failure, initial years, we had only diuretic and digoxin in our hands. Most of the patients used to be treated with diuretics and digoxin, and that was the end of the story. But in the subsequent years, we said, let us try using vasodilators. And we have been using the ACE inhibitors as our primary vasodilator, and subsequently AR2 blockers as our primary vasodilators. And that is the first step in the treatment of a heart failure, the stage B heart failure too, as well as the stage 3 heart failure, as well as continuing them into stage 4 heart failure if there is no hypotension. And ACE inhibitors became a centerpiece in the therapy of management of heart failure. Subsequent years, we realized that the sympathetic nervous system is being stimulated, overdriven, and is becoming detrimental to the myocardial cells. So we said, why don't we block the sympathetic nervous system overactivity and take the benefit of the beta blockers? And then they became, after a few trials, which I'm going to discuss in the subsequent slides, they became the cornerstone in the management of heart failure. And today, with ACE inhibitors and beta blockers, we have achieved a substantial reduction in the mortality, frequent hospitalizations, and the morbidity of heart failure patients. Of course, we have the diuretics, which have been there for many years. From the 1960s, we have diuretics here. But then spironolactone got added in our armamentarium for the management of heart failure. The RAILS trial have very clearly shown that there is a significant 27% reduction in the mortality in patients who have received the mineralocorticoid antagonist spironolactone. There have been a lot of trials on inotropic agents to improve the cardiac function, and they have been largely disappointing. We will go through those studies very briefly and see what they have a role to play. Neseritide was one very promising molecule. It's a recombinant BNP, which was approved by the FDA, which was in usage for a couple of years, but then it fell into disrepute and got discontinued as one of the management of heart failure. This is one drug wherein there was a lot of hype, a lot of hope was there on this molecule, but then it died in its course. There have been a lot of other surgical and device advances in the management of heart failure, which we will be discussing in the subsequent slides. Here is a very busy slide which I have put in from one of the journals, and then accumulated the data and said, let's look at the way we have progressed over the coming almost 30 years, where we have reached from in the management of heart failure. What we had initially, like I said, was diuretics and digoxin in the management of heart failure. In the year 1986, we had the first trial, VHEF trial, wherein a vasodilator was introduced in the management of heart failure, and they said over placebo there was a significant 16 to 18% reduction in mortality once a vasodilator was given. In the year 1987, we had the consensus trial, which very clearly showed that enalapril as an ACE inhibitor significantly again reduced mortality over and above the placebo. In the year 1991, we had three major trials. The SOLVE treatment trial, where the role of enalapril in the dose of 10 to 20 milligrams when compared with placebo again showed almost an 18 to 20% reduction in mortality. The VHEF trial, wherein ACE inhibitor enalapril was head-to-head trial with hydralazine and nitrate was done, and this again it very clearly showed that ACE inhibitors are far superior to combination of hydralazine and nitrate, which again is one of the important method of treating heart failure patients when the renal parameters are quite high. The PROMISE trial was a disappointing trial because role of oral milrinone in the management of heart failure as an inotrope failed to prove that inotropes are probably not going to be beneficial in the management of heart failure. So we had two positive trials, enalapril showing very clearly that in the SOLVE treatment trial and the VH2 trial, that enalapril is definitely there along with us for many years to come. In the 1992, it's just not class 2 and class 3 heart failure patients, but again, patients who had no heart failure. They had a structural heart disease, but were having an ejection fraction of less than 40%, but they did not have any symptoms or signs of heart failure. Were treated with enalapril, and they very clearly showed that enalapril in patients who had stage B heart disease again showed a significant reduction in progression of heart disease, recurrent hospitalizations, and heart failure. We had at this time a drug which was very, very important in the management of heart failure, carvedilol. The US carvedilol heart failure study group in the year 1996 proved that beta blockers, wherein prior teaching was that beta blockers are contraindicated in heart failure, we came around almost 180 degrees and said beta blockers are here to stay in the management of heart failure. The US carvedilol heart failure study has very clearly shown that beta blockers do reduce mortality, again to the tune of almost 24 to 28% reduction in mortality, which is seen with beta blockers. In the year 1997, the DIG study was done because this was one very, very important drug in the management of heart failure. And the DIG study showed that there was no reduction in mortality with digoxin, but definitely about 24 to 25% reduction in recurrent hospital admissions was observed with digoxin. And again, digoxin has come in as a second line treatment rather than as a primary drug treatment, which was there prior to 1980s. In the year 1999, we had the RAILS study, which has very clearly shown that adding spironolactone to the treatment of heart failure brought down the incidence of mortality by about 27%. A significant reduction in mortality with a single drug, along with ACE inhibitor and beta blocker. These three drugs have formed a major advance in our management of heart failure. Subsequent 2001, 2000, we had 3 studies showing carvedilol showing a significant benefit. This was one study which said, should beta blockers be started first or ACE inhibitors be started first? And then the role came in that you could start either drug. But personally, I would say if the lungs are wet and patient is volume overloaded, I would prefer to go with ACE inhibitors first and then add the beta blocker. But the trial has very clearly shown that one could start with a beta blocker and then add on an ACE inhibitor. The left ventricular assist device was introduced within the REMATCH study, and the REMATCH study has very clearly shown that the assist devices have definitely improved the morbidity and the survival chances for patients who are in stage 3 and stage 4 heart failure. The valsartan in chronic heart failure study was again a very landmark trial, VAL-HEPT trial in 2001, which is very clearly shown that valsartan as an ACE inhibitor, as an AR2 blocker, was a significant addition to our armamentarium for the treatment of heart failure. The device therapies which came in from 2004, the companion trial, the SCUD-HEPT trial, the CARE heart failure trial, the Maddury CRT trial, DRAFT trial, CRT in mild heart failure patients. All these trials where the device therapy wherein CRT with or without a defibrillator have very clearly shown from 2004 to 2010 that this device therapy have reduced mortality to the extent of 38% in the Maddury trial. So it's a significant advancement again over and above the medical therapy, adding a device therapy in appropriate patients where you have the QRS duration more than 130 milliseconds, you have a LV dysfunction of more or less than 40%, you have an LBB pattern, and you have a refractory heart failure. Consider a device therapy in this group of patients. In 2011, going with the RAILS trial, wherein the melanocortin antagonist was added, the emphasis heart failure trial with eplerenone again showed a similar direction, saying there is a significant benefit of eplerenone in the management of heart failure. And then we had the nesiritide in heart failure. So 2011, this was a very important drug which was in our armamentarium. We said we found the holy grail at this particular time. There was a lot of hope and hype on this particular drug, but then it disappointed. In 2014, I think, the FDA said this drug is no more to be used in patients who have acute decompensated heart failure, and it was discontinued. The Maddury CRT trial in 2014 and the Paradigm heart failure trial in 2014 have set the ball in motion and said we can do much more for our patients with heart failure. So seeing from 1986 to 2014, in these 28 years of therapy, we have reached from 2 drugs which have not shown any mortality benefit, any morbidity benefit, except for reduction in symptoms. 2 drugs, diuretics and digoxin. The subsequent 28 years, we have seen multiple drugs and devices which have shown a significant reduction in mortality with our newer drugs. Let's look at this newer drug. The LCZ696 was a new molecule which was introduced quite early in the 80s, but by the time it came into a clinical trial phase 3 trials and the article published in NEJM in 2014, I think so, very clearly showed that there's a significant role of this molecule in cardiovascular regulation. And let's look at this particular slide. It's very clearly shown that if you look at a cardiac injury and overload, if you have an injury and overload and you have a heart failure with reduced ejection fraction, we know the neurohormonal system which is activated. There's an increase in sympathetic nervous system. There's an increase in the renin, aldosterone, angiotensin system is activated, and there's an increase in the wall stress activating the natriuretic peptides. Increase in the renin system, increase in the sympathetic nervous system lead to increase in renin, increase in angiotensinogen, thereby angiotensin 1, the angiotensin 2, acting on angiotensin 1 receptor, leading to significant vasoconstriction, proliferation, activation of the radical, the fibrosis, leading to cardiac myocardial fibrosis. There is also activation of the aldosterone leading to sodium retention, thereby worsening the wall stress, the cardiac, and reactivating the sympathetic nervous system and the renin-angiotensin system. Now, this being the natural pathway what we have, a molecule called LCZ696 having 2 moieties, neprilysin inhibitor, is one molecule, and the ARB molecule, valsartan, inhibiting the angiotensin 1 receptor. With this single molecule having two moieties, we are trying to modulate the neprilysin. Neprilysin is a molecule which breaks down atrial natriuretic peptide and the brain natriuretic BNP and ANP into the residual molecules. By inhibiting these molecules, the beneficial effects of the natriuretic peptides is harnessed into the system to treat heart failure, simultaneously blocking the angiotensin system, angiotensin 1 receptor with valsartan. Thereby you get dual benefit of neurohumoral modulation rather than just neurohumoral inhibition, which we will talk about in the subsequent slides. So this molecule has neprilysin inhibition and AR2 blocker activity. And let's go to the next slide. Okay. We just take a small finish the neprilysin. And this molecule has been labeled aptly as ARNI, angiotensin receptor neprilysin inhibitor molecule. Let's look at very briefly about the pathophysiology, how the overactivation of the renin-angiotensin system and the sympathetic nervous system underpins the heart failure therapy. We all know with the RAS activation, we have a vasoconstriction, we have increased blood pressure, increased sympathetic tone, increased aldosterone secretion, hypertrophy, fibrosis, sodium and water retention, leading to volume overload, again, further activation of the RAS system. The RAS inhibitors, ACE inhibitor, AR2 blockers, and the mineralocorticoid antagonists all inhibit the RAS system, thereby giving a significant beneficial effect, which we have seen in our most of the trials. Activation of the sympathetic nervous system is blocked by the beta blockers, and we have seen a significant benefit with carvedilol, metoprolol, even bisoprolol, and most of the beta blockers have given a significant improvement in our survival patterns. The third system which is activated is the natriuretic peptide system, wherein the natriuretic peptides are formed, and we have vasoconstriction leading to decreased blood pressure, decreased sympathetic tone, decreased natriuresis and diuresis, decreased vasopressin, decreased aldosterone, decreased fibrosis, decreased hypertrophy. The natriuretic peptide system is beneficial to our system, because they reduce vasoconstriction, thereby having a lot of beneficial effects. We have hitherto, for the last 2 decades, targeted beta blockers and the RAS inhibitors in our treatment of heart failure. But the natriuretic peptide system was not harnessed. The beneficial effect of the natriuretic peptides was not taken in the management of heart failure. And here are the natriuretic peptides. They have their effect on the brain, the heart, the kidney, and the vascular system. The release of atrial natriuretic peptide and the brain natriuretic peptide from the heart and the C-natriuretic peptide in the vasculature leads to a significant effect on the brain, on the management of the kidney and the vasculature. In the brain, they decrease the sympathetic outflow, decrease vasopressin, decrease the salt appetite and water intake. The increase on the kidney, they have the effect by increasing sodium and water loss, decreasing aldosterone, and decreasing renin. All beneficial effects which have hitherto not harnessed, not taken advantage of. On the vasculature, the decreased hypertrophy, decreased fibroblast proliferation. And the C-natriuretic peptide, the endothelin, leads to arterial relaxation, leading to vasodilatation, decrease in systemic vascular resistance, decrease in pulmonary arterial pressure, decrease in pulmonary capillary wedge pressure, decrease in right atrial pressure. So many benefits of the natriuretic peptides hitherto was not taken benefit of, and that's why I said, why don't we use the natriuretic peptides in the management of this heart failure? We all know ProBNP is a molecule which is released as a pro molecule, and this is broken down by the enzyme corin when you have a vascular stretch and into BNP, which is the active molecule with a half-life of 20 minutes. This is the active hormone, and we have the NT-proBNP molecule, which is again elevated in patients who have heart failure, the half-life being 1.5 to 2 hours. This is the inactive metabolite. This active metabolite was showing all these benefits of decreasing sympathetic outflow, increased sodium and water loss, decreasing hypertrophy, and the vasodilatory effect of the C-natriuretic peptide. As long as the levels are raised, you have some beneficial effect. But we have in our system a molecule called neprilysin, which breaks down this BNP molecule into inactive fragments. And here comes the role of the neprilysin inhibitor, sacubitril, LCZ696 molecule, which has got an important molecule which inhibits neprilysin, thereby increasing the levels of the natriuretic peptides, which have got a lot of beneficial effects. The neprilysin inhibition must be accompanied by a simultaneous RAS blockade, because just inhibiting the neprilysin increases the level of the angiotensin 2 molecule, thereby producing a disproportionate increase in the angiotensin 2 molecule, thereby activating the angiotensin 1 receptor and having a lot of side effects. So a concept was created wherein you inhibit dual pathways, both the neprilysin pathway as well as the angiotensin 1 receptor pathway is blocked. Thereby you have the advantage of blocking the renin-angiotensin system and modulating favorably the natriuretic peptide system to get a benefit for our cardiac heart failure patients. And here is the flowchart which is very clearly shown. The renin-angiotensin system is activated in heart failure patients. Angiotensin 1 is secreted, leading to angiotensin 1 and 2, and thereby acting on angiotensin 1 receptor, producing vasoconstriction and all the detrimental effects of stimulation of the angiotensin 1 receptor. Valsartan is a molecule which has an established role in both the VALHAV trial and the VHAV trial. Valsartan has very clearly shown that there is a beneficial effect in heart failure patients. It was used as a molecule in this and said blocking this AT1 receptor with valsartan reduces the detrimental effects of this AT1 receptor activation. LCZ696 has a second moiety called sacubitril. This is the molecule which inhibits the neprilysin enzyme, preventing the degradation of BNP into inactive fragments, thereby producing higher levels of BNP, leading to vasodilatation, lower blood pressure, reduced sympathetic tone, reduced aldosterone levels, natriuresis, and diuresis, leading to a beneficial effect by modulating the natriuretic peptide system. So we have a single molecule having two moieties, leading to an effect on AT1 receptor as well as the neprilysin molecule enzyme. Thereby, we are producing a neurohumoral modulation rather than a neurohumoral inhibition. Here we have a system wherein we are producing a vasodilatation, natriuresis, and anti-mitotic mediators, that is the neprilysin inhibition producing rise in natriuretic peptides, producing a beneficial effect, and blocking the AT1 receptor, giving you a decreased vasoconstriction, anti-natriuretic, and pro-mitotic mediators. So we have a neurohumoral modulation, vasodilatation, increasing vasodilation, and decreasing vasoconstriction, getting a maximum benefit of this pathophysiology of heart failure. Let's look at this particular slide where why not use only neprilysin alone as a drug to get our benefits. When they tried in the phase 1 and phase 2 trials, neprilysin inhibition alone, it was ineffective due to angiotensin activation. The angiotensin 2 levels went up, and it produced an increased activation of the angiotensin 1 receptor, and then they did not get a benefit. Then they said, why not we block the angiotensin 1 receptor with our ACE inhibition? When they combined neprilysin inhibition with ACE inhibition, there was a potentially dangerous angioedema. When this very high level of angioedema was observed, both due to ACE inhibitors as well as neprilysin inhibition. So this drug was discontinued, did not come into phase 3 trials, and then they said, why don't we combine neprilysin inhibition with an angiotensin receptor blockade wherein the angioedema incidence is much less. And they found in these trials that this combination of neprilysin inhibition and valsartan produced lesser angioedema and favorably modulated the angiotensin receptor neprilysin inhibitor. That's how the word ARNI has been termed, and it's a novel drug which delivers simultaneously neprilysin inhibition and AT1 receptor blockade, and is a salt complex that comprises two active components in a 1:1 ratio. Sacubitril is a prodrug further metabolized to neprilysin inhibitor that is called LBQ657 mites. And valsartan is the angiotensin 1 receptor molecule. So two moieties in a single drug, giving you significant blockade of the AT1 receptor as well as breaking down of the vasoactive peptides, the ANP, BNP, and the CNP, thereby producing enhanced vasorelaxation and its benefits. And this was one landmark trial which was published in New England Journal of Medicine and European Heart Journal in 2013-2014, Paradigm Heart Failure, prospective comparison of ARNI with one standard drug, ACE inhibitor, enalapril, which has proved its role multiple times in multiple trials, the benefit of the enalapril in management of heart failure, compared with the standalone drug enalapril with ARNI as a combination, its impact on global mortality and morbidity in heart failure. The Paradigm Heart Failure trial has very clearly shown that the place of ARNI is here to stay. Let's look at the study itself. LCZ696 in patients with heart failure who are in 2 to 4 heart failure with an ejection fraction of less than 40% were randomized to 2 groups. LCZ696, about 4,000 odd patients, and enalapril 10 milligrams twice daily in about 4,200 patients. The primary endpoint was cardiovascular mortality or first hospitalization for heart failure. After 27 months of trial, the study was discontinued because LCZ696 was superior to enalapril in reducing the risks of death and of hospitalization for heart failure, a significant hazard ratio of 0.80 with a p-value of 0.001, a significant reduction in mortality as well as first hospitalization when compared to enalapril, which was a very standard drug in management of heart failure. Let's look at the key inclusion criteria. Chronic heart failure patients in class 2 to 4 with ejection fraction of less than 40%, a BNP level cutoff values we are all familiar with. They had to be stable for 4 weeks. Chronic heart failure patients were stable with an ACE inhibitor or an AR blocker. Acute decompensated heart failure patients were not included in the trial, and they had to be an ACE inhibitor and a beta blocker and an aldosterone antagonist as a baseline therapy in almost all the patients. About 80 to 90% of the patients were on these 3 drugs. Certain exclusion criteria were used. Somebody who had a history of angioedema with a GFR of EGFR less than 30 ml, a serum potassium of more than 5.2, and symptomatic hypotension, acute decompensated heart failure, severe pulmonary disease, acute coronary syndrome, myocardial infarction, stroke, transient ischemic attack, carotid and cardiac disease, major cardiovascular surgery. These patients were excluded from the trial. The safety endpoints were serious adverse events, hyperkalemia, symptomatic hypotension, increased serum creatinine, angioedema, regular monitoring necessary for these points. In any patient who receives ACE inhibitor, the same points are used for patients who are being given this ARNI molecule. When you study this baseline characteristics, about 4,187 patients for the LCZ696 molecule versus 4,200 patients for the enalapril molecule, they are equally balanced. The ischemic cardiomyopathy, about 60% of the patients, the diabetes in about 34% of the patients, and the usage of the drugs, 80% diuretics, 29% digitalis, beta blockers 93%, mineralocorticoid antagonists 54%, a little less than what is expected. And mind you, about 15 to 20% of the patients were on ICD or CRT. So in addition to the drugs, these patients were being managed with device therapy, which have shown in many landmark trials, especially Maddury 2 trial, that there is a benefit of these device therapies. So over and above the device therapy, over and above the standard triple regime of beta blocker, ACE inhibitors, and mineralocorticoid antagonists, reducing the mortality by 3 times, this drug has shown its role in the management of heart failure. The key results in this Paradigm Heart Failure trial, there is a significant 20% reduction in mortality of cardiovascular causes or first hospitalization. There was a significant reduction in death from CV causes, again a 20% reduction from cardiovascular causes of death, and first hospitalization was reduced in about 21% of the patients, over and above the usage of enalapril, over and above the usage of beta blocker, over and above the usage of mineralocorticoid antagonists, over and above the usage of the device therapies of CRT or ICD. This was a significant, and when you look at the death from any cause, there's a significant 16% reduction in death from any cause. It's a drug which has shown very promising data so far, over and above the baseline foundation therapy what we had for the heart failure. There were some adverse events leading to study drug discontinuation, and they were comparable to enalapril, almost comparable to enalapril. Hypotension, renal impairment, and hyperkalemia, they were almost comparable in their this one. But for renal impairment, enalapril had definitely a higher p-value in this patient, but hyperkalemia was almost comparable with ARNI and enalapril. So the of these efficacy results, this is 20% reduction in cardiovascular death, 20% reduction in CV mortality, 21% reduction in first hospitalizations. A lot of secondary outcomes were also there with this drug, 16% reduction in all-cause mortality with LCZ696 versus enalapril. There was no significant difference in the incidence of new onset atrial fibrillation between the treatment groups, and there's no significant difference in the protocol-defined decline in renal function between the two treatment groups. So the renal function was not adversely affected when compared to enalapril in this major trial, and there was significant mortality benefit. And a titration study was done with the dosages, what dosage was suitable for this, what dosage should be started with, and the titration study was very clearly shown after a short period of 5 days when they started patients on LCZ696 at 50 milligrams twice daily versus 100 milligrams twice daily, and went on to increase the dosage after 2 weeks to 100 milligrams twice daily and 200 milligrams twice daily, condensed initiation and uptitration over 3 weeks, conservative initiation and uptitration over 6 weeks, and they found that the initiation and uptitration of LCZ696 was well tolerated, regardless of the uptitration regime, whether it was initial condensation and uptitration or gradually titrating the dosages. The dosages were well tolerated, and this drug, starting at a lower dose and then uptitrating to a higher dose of 100 milligrams twice daily, has very clearly shown that this drug has a lot of promise today. Hyperkalemia is one major.
Before the hyperkalemia, I think the evaporatin is also an important, especially when the patient has the sinus rate and greater than 70.
We had one landmark trial. I am sorry, I would have skipped the slides a little bit. I just wanted to continue the slides.
Yeah. I think
one drug which has come into was in 2010. We had a trial called SHIFT trial, evaporatin therapy in patients with chronic heart failure, symptomatic patients in heart failure, over and above beta blocker usage, ACE inhibitor usage, mineralocorticoid usage. When they were prescribed evaporatin, this molecule which has an effect on the IF channel, the funny current channel inhibitor, evaporatin, where it acts on the SA node and reduces the heart rate. When it was compared with the placebo in about 3,200 patients versus evaporatin 7.5 milligrams twice daily, the primary endpoint of CV mortality or hospitalization for worsening heart failure, there was a significant 18% relative risk reduction in mortality as well as heart failure hospitalization in the evaporatin group when compared to the placebo. Evaporatin significantly reduced the major risks associated with heart failure versus placebo, and it improved the clinical signs and symptoms when added to the guideline and evidence-based treatment of heart failure patients over and above the beta blocker therapy. So in 2015, this drug was accepted and approved by the FDA as one of the standard drugs for the management of symptomatic chronic heart failure with an ejection fraction of less than 35% and who are in sinus rhythm with a resting heart rate of 70 or higher and who are on maximally tolerated dose of beta blocker or have a contraindication to beta blocker. This drug has made a significant change.
Yeah, actually, this is for this SHIFT trial. NIMS is one of the center recruited the cases also. So even though the FDA approval is given in the 2015 as an indication with a heart rate more than 70 heart rate, but actually the study has come as early as 2011.
2010, yeah. 2011. Yes.
But a major problem with all these combinations is hyperkalemia. So I think the management of this hyperkalemia is also equally important. Just by the stoppage of the drug or reduction of the drug, we are losing the efficiency of the drug. So example, if the patient develops an hyperkalemia and immediately we stop the RNA dose, then the mortality benefit is we are losing it. So there are the two more drugs which are introduced mainly to manage this hyperkalemia patients. These are peteromer calcium and zirconium silicate. This is mainly prevents an absorption of the potassium from the intestines. This is an FDA approved now, and this is one of the new drugs added along with the heart failure management guidelines of 2016. See, peteromer is a classic used in the clinical trials and demonstrated this drug is in treating hyperkalemia in at-risk population for periods ranging from a few days up to the 12 weeks. The two studies which proved its efficiency in decreasing hyperkalemia with the continuation of the other drugs which are essential for the management of the heart failure are PERL, HF and OPAL, HK. This zirconium silicate mainly absorbs the absorption of the potassium from the intestine, but it prevents even ulcer formation also. The major problem in the concentration of the potassium in the distal intestines increases that produces the ulceration. But this drug is able to take care of that also. Just
we have a lot of newer novel agents in heart failure. I mean, a lot of concepts are there, a lot of drugs have been tried. Like the initial trial of oral milrinone, which was tried to as an inotrope to improve the outcomes. It failed. But there have been a lot of other newer inotropes which have been tried. I think
actually, mainly these are the slides mainly mentioning about at what level we can try to control the heart failure, like newer inotropes or vasodilators, relaxin, sterilacin, and neuroregulants. That is a very important associated with other conditions also. Novel RAS blockers, and some of the things are the relaxin, especially produced from the natural pregnancy hormone secretion. So it is like a side effect of the drugs or the analyzed in that, like a dual AC NEP inhibitions and triple enzyme inhibitors, dual dopamine D2 and alpha 2 agonists, dopamine beta hydroxylase inhibitors, adenosine A1 receptor antagonist, the drugs acting on the carnitine palmitate transferase. This is an enzyme inhibition, matrix metallase protease inhibitors, and immunomodulators. All these things requires a mention because in a specific group and very limited studies, these drugs are used. So we can't say that all these novel agents with the inotropes has an equal efficiency, like in the cardiac myosin activators or as agents acting on the SRCA2 and sodium potassium ATPase inhibitors, ranodine receptor stabilizers, and metabolite modulators. All these things are also is not proved in effect. In essence, if you in general we can give some of the statements of this novel therapeutics are these newer therapeutics may be potential candidates in future for heart as increasing the understanding of pathophysiology of heart failure. Agents directly acting on the remodeling process may is the current pathological condition of the heart failure. Newer agents are seems to be beneficial over the older one in efficiency and the safety wise. That is newer inotropes and the RAS antagonists. But it is not a proved value in decreasing the mortality. Especially the gene therapy is also emerging as a new technique for a heart failure. But still it requires a further studies. Whenever the fluid overload is there, unloading with an ultrafiltration during acute compensated heart failure stage proved to be very effective in improving the patient's symptomatic state. But is that decreases the mortality is not yet proved. The largest studies are needed to establish the effect of ultrafiltration on the long-term outcomes of the mortality and the heart failure.
So today, do you use your ultrafiltration in patients who have chronic heart failure, who have a lot of fluid overload, who have a borderline renal function? Do you do in your daily practice use this ultrafiltration?
Yeah, we have done it. In acute heart failure, more frequently used than in a chronic heart failure. The major advantage in acute heart failure is we have some precipitating factor. So controlling the precipitating factor along with an ultrafiltration, some people even require the CRRT other than superadded to the ultrafiltration, definitely prove to be beneficial. But this is for the symptomatic improvement, tie over the crisis.
In patients who have a renal failure and stage C heart failure, who are not suitable candidates for a regular dialysis, who are not candidates for a hospitalization, one can try peritoneal dialysis. Peritoneal dialysis as a modality has very good advantages in patients who have a chronic heart failure and a renal failure, wherein recurrent hospitalizations can be avoided and an ambulatory peritoneal dialysis can be done. A good amount of fluid can be removed, and if the patients are taught well, they can maintain the renal function and the renal replacement therapy for many years in a very well balanced state. Also manage the heart failure in a very well managed state with the drugs what we have. So peritoneal dialysis, ultrafiltration, ultrafiltration in acute decompensated heart failure, and peritoneal dialysis in patients who have a chronic heart failure with a renal impairment or renal dysfunction is a good modality.
Yeah, the point is very well taken, because in peritoneal dialysis, acute heart failure is slightly different from the chronic heart failure. Once in acute heart failure, because of the fluid overload in the already present in the lung, and the diaphragm is in an elevated position because of the peritoneal dialysis, the tolerance by the patient is not very well.
Agreed.
Whereas in the chronic heart failure, it is in a very good modality.
Yes.
So also in the obesity associated obstructive sleep apnea syndromes, the CPAP therapy is very, very important. There's a 3 months treatment with the sleep apnea has demonstrated increase in the left ventricular ejection fraction when compared to the sham CPAP model. But this benefit is demonstrated in the patients who has a ejection fraction more than 30% along with obstructive sleep apnea, but the same equal benefit is not demonstrated when the ejection fraction is less than 30%.
In fact, in our day-to-day practice, what we see to observe is the patients who are refractory heart failure or going into recurrent heart failure, one major diagnosis which is missed, which is overlooked, is obstructive sleep apnea. This one condition makes the patient very simple, and a very simple treatment with CPAP or BiPAP makes the quality of life significantly better. So recurrent heart failure, refractory heart failure, do consider obstructive sleep apnea as one of the entities which is worsening the heart failure, and maybe doing a sleep study, a polysomnography appropriately, will give the benefit to the patient. A simple therapy with CPAP or a BiPAP would make a lot of change in the quality of life.
Yes, that's true. What about iron replacement therapy?
Yeah.
Is that is indicated in all heart failures, or below the 11 grams for a male and 10 grams for a female, like that? Or really it requires the iron deficiency to be proved to start the treatment?
Iron deficiency was one of the major targets in the European Society of Cardiology when the trial was given in, which very clearly said that if the iron deficiency is diagnosed when the serum ferritin was less than 100 micromoles per liter, or when the ferritin concentration was between 100 to 299 micrograms per liter, and transferrin saturation was less than 20%, that was when you make a diagnosis of deficiency of iron deficiency anemia. Iron therapy improved the overall patient symptoms. They also contribute to the iron deficiency, also contributes to the muscle dysfunction in heart failure. It also improves the quality of life. It improves the breathlessness, the shortness of breath, what the patients complain, have significantly improved when you replace iron with ferric carboxymaltose infusion. And this is one major therapy which again is neglected or missed in management of heart failure. So a patient who has a borderline hemoglobin, and who needs who has iron deficiency, do replace iron and you get a significant benefit. Here is the suggested treatment algorithm for patients who have iron deficiency.
One question is, so you need not to see the hemoglobin levels. If
Yes.
you have the documented these parameters, you will treat it.
Agreed. So I would maybe, for all heart failure patients, do the iron studies and see what are the serum ferritin and transferrin saturation levels. And the confirmed heart failure trial was one major trial. It's an evidence-based confirmed heart failure trial which has clearly shown that ferric carboxymaltose in 1000 milligrams to 2000 milligrams, single or more doses of 500 to 1000 milligrams to correct the iron deficiency. Check ferritin and the transferrin saturation within the next scheduled visit of 1 to 3 months and see, if necessary, give a second dose of the carboxymaltose 500 milligrams to maintain a serum ferritin and T-sat on target. This was the confirmed heart failure trial, which has very clearly shown that iron deficiency has to be treated aggressively in patients who have heart failure. Not only the regular drugs, the obstructive sleep apnea, iron deficiency also has got a significant role to play in improving the symptoms in patients with heart failure.
Actually, we have done a study in the NIMS. The normal level of the ferritin, we classified into the 4 quarters, the first, second, and third, and fourth quarters. who are in the first quarter, when compared to the fourth quarter, those people has a higher event rates. So probably not only for the treatment, we can use as a prognostic marker also.
Yes.
This is an iron deficiency.
Yes, true the same.
So till now we are talking about the extensively with the drug therapy, which is the main therapy. And few of the devices are very, very important. For our today presentation is not mentioned to know about the CRT, which is really is approved best benefit in heart failure patients is the CRT. But as such, we are not talking about the CRT therapy and improvement of the mortality and patient survival rates at the present. But this is approved the best out of all the drugs. And the next one is RNA. So the one of the modalities is resynchronization and the support of the to give a left ventricular assist devices up to the extent of either a tandem heart or a simple one, so the impella can be the tried. And is right hand catheter pumps. These are the mainly used to assist the left ventricular load to decrease and improve the cardiac contractility. And there is some algorithm we can follow it. Like when the patient has the ejection fraction less than 35% and the patient has a coronary artery disease, it is not a complex lesion. Without any support, we can directly go for the simple PCI, even with the ejection fraction is less. When the ejection fraction is between the 20 to 35% and is a PCI complexity is not there, probably with IABP we can go. But if the complex PCI, better to take an impella or some other ventricular assisted devices. So also when the less than 20%. So the other things are very important ones are left ventricular restoration devices. This is with the parachute mitral valve. When there is a left ventricular aneurysm, exactly this is a parachute device will implanted at the area of the aneurysm neck, and it obstructs the neck so that the aneurysm is excluded from the contractility of the LV. So that two things happens. One thing is arrhythmia incidence decreases. Second one is contractility improves because ineffective contracting aneurysm is excluded from the total contraction. So the parachute device is used.
Formation also is.
Yeah, will be prevented. Like the other one is left to right interatrial shunt. As we already know, the left atrial pressure whenever increases, pulmonary capillary wedge pressure increases. So the one of the measures is to decompress the left atrium, but at the cost of increasing the right atrial pressure. But once the right atrial pressure also start increasing by producing the intra-atrial septal communication, then there is no benefit. There is equalization of the pressures. So we should have a device which will allow a unidirectional flow of the blood from the left atrium to the right atrium, whatever may be the pressure of the left atrium. So then it can be the decompression on the left side happens, so that pulmonary capillary wedge pressure comes down. That is one of the device is the V valve device. The first in man implantation is already done for this, and the efficiency is demonstrated in the 5 patients. And of course, there is a pulmonary artery pressure monitoring. Either you can put directly into the pulmonary artery or right into the SVC junction. In some of the cases, they even puncture to the intra-atrial septum and put into the left atrium and monitor these pressures. With the knowing these pressures, the diuretic doses will be adjusted by the device, and it delivers an extra doses of the diuretic.
So a tailored therapy can be done.
Yes.
Depending on the patient is going for acute decompensation, or you would know beforehand.
Beforehand itself, before the patient develops a clinical symptom.
You can uptitrate your drug dosages and maybe manage them more as per the hemodynamic parameters.
That's true. But this is not still proved, and a few of the some drawbacks because of implantation produce a more frequent infections. So these devices requires an improvement. So also the presence of the mitral regurgitation requires treatment as separate than the remodeling of the left ventricle.
So in most of the patients with cardiomyopathy, ischemic cardiomyopathy or dilated cardiomyopathy, you have a dilatation of the heart, dilatation of the mitral ring, mitral regurgitation happening. Mitral regurgitation begets mitral regurgitation. As the mitral regurgitation worsens, the heart failure worsens. Here is one system which is very clearly shown. Using the mitral clip system, which is a semi-invasive procedure, wherein you can reduce the severity of mitral regurgitation significantly, and thereby reduce the the mitral regurgitation, the left atrial overload, and the pressures, and thereby favorably modulate the mitral regurgitation and the heart failure management.
Yes. The European guidelines are also is there that a symptomatic patient, despite the optimal medical therapy, including the CRT, the severe MR, is an indication to treat that MR with the mitral. And another thing is in high risk patients who are not inoperable, then also we can try this, but they should have a life expectancy should be more than 1 year. Of course, anatomically is very, very important. There are the criteria to do whether this is suitable for the mitral clip or not. Of course, the clinical profile is a major determinant to take for this device. So also there is the reduction of the coronary sinus devices to remodel the annulus of the mitral valve. Yes. And so also percutaneous septal sinus shortening devices are available. And ventricular remodeling, the other one is I-coapse system, that is externally compression. Either we can do this surgically or percutaneously implantations can be done to decrease the anterior-posterior diameter of the left ventricle to decrease it. This is tried in the TRACE and the RESTORE MB trials, which are ongoing trials. Other novel approaches are surgical mitral valve repairs, that is the caudal repairs, either implantation of the cardia or the removal of the overstretched cardia, and the transcatheter and percutaneous caudal procedures, and even the mitral valve replacement percutaneously is tried. First in man implantation of the mitral valve is done. Of course, the renal denervation for the hypertension management is also improved the heart failure management. That is demonstrated in the Simplicity Hypertension 3 trial. This improvement is not only symptomatic, even increase in the heart failure. In one of the study, even they demonstrated decrease in the arrhythmia incidence also. Of course, not last, but important one is cardiac transplantation.
In 2016, the ACC and the European Society of Cardiology had given certain guidelines to improve the care of patients with heart failure. And going by the level of evidence what we have, there has been an updated clinical practice guidelines on heart failure and international alignment. Both the ACC, American College of Cardiology, and the European Society of Cardiology have seen eye to eye and given 2 updated clinical practice guidelines on the management. The introduction of ARNI, sacubitril with valsartan combination, and an SA nodal modulator, ivabradine, when applied judicially, complement established pharmacological and device-based therapies representing milestones in the evolution of care of patients with heart failure. And we have the level of evidence which have been given very clearly again. Level A is a high quality evidence from randomized controlled trials, more than 1 randomized controlled trials. Level B is a moderate quality evidence-based trial from 1 or more randomized controlled trials or meta-analysis of moderate quality randomized controlled trials. Level BR is randomized. BRR stands for randomized. Level BNR is non-randomized, a moderate quality evidence-based trial from 1 or more well-designed, well-executed non-randomized studies, observational studies or registry studies, having given a lot of data, but they are non-randomized. Level C, where there's limited data. Level C, LD is limited data. Level C, ED is expert opinion, the consensus of expert opinion based on clinical experience. The new level is level B, randomized. Now, when you look at the level of evidence for most of the drugs, which drug has to be given? What is the level A? So if you look at the recommendation, pharmacological treatment for stage C heart failure with reduced ejection fraction. For ACE inhibitors, level of evidence is A. For AR2 blockers, level of evidence A. For ARNI, angiotensin receptor blocker with neprilysin inhibition, level of evidence is B, randomized trial. And based on a very good randomized trial, paradigm heart failure trial, we have said this is a class 1 indication, but level of evidence is B. So they're all class 1 indication of drugs, all a class 1 recommendation. The clinical strategy of inhibition of the renin-angiotensin system with ACE inhibitors, AR2 blockers, or ARNI ARNI is level of evidence B, but class 1 indication. In conjunction with the evidence-based beta blockers, aldosterone antagonist in selected patients is recommended for patients with chronic heart failure, reduced ejection fraction to reduce morbidity and mortality. So, RAS system modulation is a class 1 indication. Either you do it ACE inhibitors, AR2 blockers, or ARNI. Very important. Recommendations for ARNI. It's a class 1 B level indication. Sacubitril valsartan is recommended as a replacement for an ACE inhibitor to further reduce the risk of heart failure, hospitalizations, and death in ambulatory patients with heart failure with reduced ejection fraction who remain symptomatic despite optimal treatment with an ACE inhibitor, a beta blocker, and a mineralocorticoid antagonist. So it says if somebody is still symptomatic over and above the treatment with ACE inhibitors, beta blocker or MRA, one should replace ACE inhibitor with ARNI. But mind you, the gap between ARNI introduction and discontinuation of ACE inhibitor should be at least 36 to 48 hours. The drug should not be used as simultaneously or without a gap of 36 to 48 hours. Recommendations for renin-angiotensin system inhibition with ACE inhibitor or ARB or ARNI. Level 1 indication, ARNI is BR, randomized trial, level of evidence is B. In patients with chronic symptomatic heart failure with reduced ejection fraction, NYHA class 2 or 3 who tolerate an ACE inhibitor or ACE inhibitor, who are already on ACE inhibitors, who are already on AR2 blockers, replacement by an ARNI is recommended to further reduce morbidity and mortality because over and above the enalapril, ARNI has shown a 20% reduction in cardiovascular death and hospitalization. So substitute, the recommendation today substitutes ACE inhibitor and ARB with an ARNI. So level of recommendation 1, level of evidence BR. If you look at recommendations for ivabradine, the level of recommendation is class 2A and its level of evidence is B, based on one randomized trial. Significant data has been accumulated. Ivabradine can be beneficial to reduce heart failure hospitalizations for patients with symptomatic class 2 or class 3 stable chronic heart failure who are receiving goal-directed or evidence-based medical therapy with beta blocker at maximum tolerated dose, who are in sinus rhythm with a heart rate of more than 70 or higher. It's a class 2A recommendation. Ivabradine is a class 2A recommendation today, level of evidence BR. What is important is patients not taking an ACE inhibitor or AR2 blocker or previously taking it at a low dose. One has to start with a lower dose of 24 milligrams by 26 milligrams. Double the dose every 2 to 4 weeks to get a target maintenance dose of 97 by 103 milligrams. That is 200 milligrams BD dosage as tolerated. Mild to moderate renal impairment, there is no starting dose adjustment required. If the GFR is more than 30, you don't need any adjustment in the starting dose. But if the GFR is less than 30, reduce the starting dose by 50%. If there is a hepatic impairment, for mild to moderate, there's no significant starting dose adjustment required. But for severe heart failure, this drug is not recommended. For severe hepatic impairment, this drug is not recommended. It's contraindicated when you have a concomitant use of an ACE inhibitor, or if you're switching from an ACE inhibitor to a ARNI combination. Allow a washout period of 36 hours between the administration of the two drugs. This is a very, very important point. So let's summarize what we have, what are the take-home messages we have today in the management of heart failure.
Definitely, I would like to hear from you because so extensively you talked about the ARNI and ivabradine, which are the new introductions. So I wanted to know what is the message you wanted to give to our listeners.
As said in the initial slide, the incidence of heart failure is increasing, not only in the younger population, not only in the older population, but also in the younger population. Males are being affected more in the Indian subcontinent than the females. Drugs with proven benefit, mortality benefit, level of evidence A, class 1 indication, ACE inhibitors, AR2 blockers, beta blockers, aldosterone antagonists, ivabradine. Ivabradine is class 2A indication. Over and above these drugs, we have the device therapies which have very clearly shown a significant 38% mortality benefit. And over and above the device therapy and the standard triple therapy of ACE inhibitor, beta blocker, mineralocorticoid antagonist, ARNI has shown through the paradigm heart failure trial that there is additional benefit, additional mortality benefit, additional recurrent hospitalization benefit, additional CV death reduction with this molecule ARNI. What is important is these drugs have to be monitored. Very, very important. The blood pressure has to be monitored. The renal parameters have to be monitored. EGFR has to be monitored. Potassium has to be monitored. But we have today in our armamentarium an additional drug which can control the potassium levels along with the drugs, ACE inhibitors and AR2 blockers or ARNI, to reduce the potassium levels and thereby not discontinuing the standard drugs for management of heart failure. Pyromer calcium and zirconium silicate are the two drugs which have been used for hyperkalemia management, which can be prescribed along with, side by side with ACE inhibitors and AR2 blockers, so that dangerous hyperkalemia levels, dangerous potassium levels are not achieved or reached. In very appropriate indications, CRT and CRTD has had a major impact on the modality, and newer modalities like left ventricular assist devices, mitral regurgitation management with MitraClip, or the parachute device to exclude the aneurysm from the left ventricular cavity are major roles to play in the management of advanced heart failure. So also the HeartMate 2, HeartMate 3, and a cardiac transplantation as a bridge to transplant or a transplantation itself have going to change the management of heart failure patients to a great extent, giving them quality of life and quantity of life.
Yeah, in this webinar, actually, we covered the definition of the advanced heart failure, the previous management strategies, and the recent introduction in the 2016, and then evidence-based for that, and
the
guidelines. I am really thankful to you, Dr. Seshi, for such an extensive, clear indications and explanations for each drug. I think it is hopefully it is helpful to all the people. And if you have any queries or anything, both of us emails are given along with this presentation. So please, you can mail to us, and we will be happy to communicate with you all.
Thank you, Dr. Jyotsna. That was a good discussion on the management of heart failure. I think that this will go a long way in our management of heart failure patients.
Thank you. Thank you.
Good day to you.